Good morning, everyone. I am Sandeep Sahai, and I welcome you all to the weekly edition of Houston Methodist DeBakey Cardiology Grand Rounds. I am here joined with Dr. Raymond, who is our advanced heart failure and transplant cardiologist with interest in pulmonary hypertension.
Good morning.
And I am Sandeep Sahai. I am a pulmonologist here at Houston Methodist with interest in pulmonary hypertension. And today we have great pleasure and honor to introduce our speaker, Dr. Raymond Benza from Ohio State University. Dr. Benza is a professor of medicine at the Ohio State University in Columbus, Ohio, and an adjunct professor in the School of Biomedical Engineering, Carnegie Mellon University in Pittsburgh, Pennsylvania. He is also the Bob and Corrine Frick Endowed Chair of Heart Failure at the Ohio State University Wexner Medical Center. He is a fellow of the American College of Physicians, the American Heart Association, Council on Clinical Cardiology, the American College of Chest Physicians, and the American College of Cardiology. He is a diplomat of the American Board of Internal Medicine with certification in the subspecialties of cardiovascular disease and advanced heart failure and transplantation. Dr. Benza currently holds a position on the governance committee at the International Society of Heart and Lung Transplantation and is the former treasurer of the society. He served on President Barack Obama's advisory committee on organ transplantation in the Health Resource and Service Administration for 4 years and was knighted in 2015 by His Royal Highness Vittorio Emanuele of Italy for his philanthropic work in patients with pulmonary arterial hypertension. His primary clinical interests are the evaluation and treatment of advanced congestive heart failure, cardiac transplantation, and pulmonary arterial hypertension. He participates in major clinical studies of newer therapies for the treatment of heart failure, mechanical circulatory devices, and pulmonary hypertension. Dr. Benza is funded investigator for the NIH and American Heart Association for his work in pulmonary arterial hypertension, focusing on risk stratification, pharmacogenomics, and new devices for this disease state. With that introduction, I would like to hand it over to Dr. Benza. Good morning, Dr. Benza.
Morning.
Good morning, and it's such a pleasure to be here virtually in Houston, and it's much better there than it is here. We are having a little blizzard right now, so I hope everyone is nice and warm and toasty down there. Thank you for that really great introduction today, and my job today is to lecture to you on a very common topic, which is pulmonary hypertension that afflicts those patients with left heart disease, which is a very common entity, as you will see. So let me go ahead and share my slides, make sure that that's working.
I want our audience to send their question by web by going to paulev.com, enter DeBakey, and respond with your questions, or you can text to us DeBakey to 37607. Thank you, Dr. Benza.
Okay, thank you, Sandeep. So today we're going to be speaking about the management of group 2 pulmonary hypertension or pulmonary hypertension owing to left heart disease, and whether there is or is not adequate treatment for this disease. And what I'll show you and what we'll present today is the following outline. We're going to talk, let me see if I can get my slides to advance. There we go. So today we'll be talking about the prevalence and impact of group 2 pulmonary hypertension, how it's classified, the pathophysiology and the pathology, where I'm going to convince you that this is not a 2-compartment disease, but really a 3-compartment disease, and that the management of this disease is based on those 3 compartments. And then we'll talk a little bit more about some innovative new technology that we can use to monitor this disease. So let's start with the prevalence and the impact of group 2 pulmonary hypertension. As many of you know, we have 5 primary groups of pulmonary hypertension that we see clinically. And the focus of today's talk is pulmonary hypertension due to left heart disease, whether that's systolic dysfunction or diastolic dysfunction, or from a valvular disorder like aortic stenosis or mitral insufficiency, and from a variety of congenital abnormalities. Now, when we look at group 2 pulmonary hypertension, there's something that is unusual about this disease. We all think that pulmonary hypertension is a rare disease, but in actuality, group 2 pulmonary hypertension is very common, and it's also the most common form of pulmonary hypertension that we see in the clinic, as you can note from this pie chart. In fact, I try to teach my residents that when you are evaluating someone with pulmonary hypertension in your clinic, 7 out of 10 people who's referred to this disease will have group 2 pulmonary hypertension. It is the most prevalent form of pulmonary hypertension that we see. And when you look at the presence of pulmonary hypertension in the community, and this is taken from the very famous Minnesota study, you can see that in people age 45 and above, that 50% who were imaged with echocardiography actually had an abnormal pulmonary artery systolic pressure. And 25% of those actually had a PA pressure greater than 30 millimeters of mercury. This is a very prevalent problem in our community, and most of this is owed to pulmonary hypertension related to left heart disease. You'll also notice that as the PA pressure increases, that the mortality from this disease also increases with it. And that's shown very nicely in this slide. So that in every quartile of pulmonary artery systolic pressure that was raised, you can see that the 8-year mortality steadily increased with the presence of PH, whether you had other cardiopulmonary disease evident or not. So this is a really bad player. And 50% of these people that we will see will have very significant pulmonary hypertension with PA systolics greater than 30 millimeters of mercury, in which the mortality rate is very, very high. And so if you do a little bit math here, we know there are about 48 million Caucasian people in the US greater than 45. If up to 25% of the US Caucasian population greater than 47 has echo evidence of pulmonary hypertension, and pulmonary hypertension, as I just showed you, is equated with decreased survival, we have about 12 million Caucasian adults greater than 45 with an abnormal PA pressure that are at higher risk of dying related to this disease. This is common, it's a bad player, and it needs to be recognized. So how common is pulmonary hypertension actually within the frame of heart failure itself? Well, if you look at patients with either reduced ejection fraction or preserved ejection fraction, you can see that it's extremely common. And people with HFrEF, 40 to 80% of patients will have pulmonary hypertension coexistent with this disease. And if you look at people who have heart failure preserved ejection fraction, up to 52% of these patients will also have concomitant pulmonary hypertension. So let's do that math again. So if there are 5 million people in the US with heart failure, 2.7 million people with HFrEF and 2.3 with HFpEF, we have 62% of all HFrEF and 52% of all HFpEF have PH. And again, PH correlates with decreased survival. We have about 1.7 million US citizens with HFrEF and about 1.2 million US citizens with HFpEF that also have group 2 pulmonary hypertension who are at high risk for mortality. That's a heck of a lot of people. So this is a prevalent disease. Now, the interesting thing about this disease is when you look at the mortality that's associated with pulmonary hypertension, you can see that those with active congestive heart failure, that the change in mortality is very linear with the change in pulmonary capillary wedge pressure. But when we look at the pulmonary pressure, we see something very distinctive, that there's actually a threshold effect. So that when the PVR gets greater than 2.5 Woods units, that's when people are really going to start to experience the higher mortality with this disease. So these are the people we really have to concentrate and identify in this left heart disease population. So what's the prognostic significance of patients with heart failure who also have pulmonary hypertension? Well, if you look at the mortality rate, you can see that whether you have HFrEF or HFpEF, that the mortality rate is much increased when pulmonary hypertension is part of this disease. But you can also see that this is dependent on the PVR, like I just said, with a threshold effect, but there's also a substantial effect on morbidity. There's a significantly increased hospitalization rate for patients with heart failure who have pulmonary hypertension. So this disease is not only a bad offender for mortality, but also for morbidity, and it's correlated highly with the PVR. So what I hope I have impressed upon you is that when present, pulmonary hypertension with left heart disease really exerts a negative impact on outcome and results in more severe symptoms and worse exercise tolerance in this patient population. So let's move over now to classification and talk about how we classify group 2 pulmonary hypertension. Well, this is the old classification system in which we kind of grouped etiologies of left heart disease that can create group 2 pulmonary hypertension. And then we'd split them into people who had passive pulmonary hypertension directly related to the wedge pressure, or mixed pulmonary hypertension, meaning that there was concomitant vascular disease that was causing the increased pressure, not only a backflow of pressure from the left atrium. But we've changed this classification system a little bit now. So we've renamed these two categories into isolated post-capillary pulmonary hypertension and then combined pre-capillary post-capillary pulmonary hypertension to get down to a little bit more about the pathophysiology of this disease. And when we define these, you could see that they're both defined similarly. Both have to have a mean pulmonary artery pressure greater than 25 millimeters of mercury, and both have to have a wedge pressure LVEDP greater than 15. Now, the difference between these two is the absence or presence of actual pulmonary vascular remodeling. In patients with combined precapillary and postcapillary pH, you have a very high transpulmonary gradient and an elevated PVR, where you don't in those patients with isolated postcapillary pH. And now we also describe the diastolic pressure gradient, which omits the impact of stroke volume on the pressure determinant, and allows us to differentiate these classes a little bit better into those with the vascular disease and those just with back pressure related to it. Now, when you look at the mortality that's associated with these different phenotypes of group 2 pulmonary hypertension, and in using patients who don't have PH and those who have pulmonary arterial hypertension or group 1 disease, you can see that patients with group 2 pulmonary hypertension also have a much higher mortality, and especially when you have those patients who have combined precapillary, postcapillary pulmonary hypertension, that they have a mortality almost equal to those patients with pulmonary arterial hypertension. That is a deadly disease, and we really have to keep that in mind, and keep that in mind as to why we need effective therapies and management people for these people, because the 5-year survival rate is less than 50% in those patients with heart failure or left heart disease and combined precapillary pulmonary hypertension. So now let's dive into a little bit about the pathology and pathophysiology. And remember, I want to convince you that this is not just a 2-compartment disease related to the left atrial pressure and the pulmonary arterioles, but there's a third compartment that's very important to this disease, which are the pulmonary veins. So let's look at this. I'm going to show you what now the classic mechanism of pulmonary hypertension in group 2 disease. As you know, it all starts with a passive increase in mean pulmonary artery pressure that's due to an increased left atrial pressure, no matter what the mechanism is. What this does is then it infers a change in the phenotype in the cells that comprise the pulmonary vasculature that relates to endothelial dysfunction, in which vasoconstrictor substances and growth factors are elaborated, and those substances that vasodilate the blood vessels and make it undergo programmed apoptosis are reduced. And this results in significant arteriolar remodeling in this disease. Now, if I were to show you what this looks like pathologically and show you these two slides, one of these patients actually has IPH and another person has CPCPH. And if you look at these arterioles, well, to me, they look pretty similar. So pathologically, in the arterial cascade, these are indistinguishable one another. So the patient on the left actually has CPCPH, and the patient on the right actually has IPH. So on the arterial level, these diseases are almost identical. Now, the correlation between pulmonary artery pressure and medial thickness is very close. And when you look at this, you could see that those with a higher pulmonary artery pressure are the ones that really have the arterial remodeling with this disease. Now, what I'm going to show you next is probably the most important part of the lecture, because it really is central to how I feel we need to treat this disease. Now, when we go back to the pathology of this disease and we look at the pulmonary veins, you can see that on the right, with patients with PH with left heart disease and CP-CPH, there is significant venous remodeling. These veins are thick. They now have a media where before they did not have a media. And this is a really key pathological finding that really should influence how we treat this disease. So venous remodeling is the overlooked compartment, and I'm going to tell you why that's important. When you look at the factors that actually migrate and produce venous remodeling in this disease, you can see that the activators are entirely different than the activators that we see that remodel arterioles. These are plasminogen activators and metalloproteinases, where in arterial disease, we have endothelin and prostacyclin. So it's not unusual, and it's very explainable why the drugs that we use to treat pulmonary arterial disease don't have a major effect on remodeling the veins. And I want everyone to keep that in the front of their mind, because not being able to treat these veins is really the Achilles heel of how we treat this disease. So we now look at the contemporary stages of this disease. You can see that patients progress from isolated post-capillary PH, in which there is no vascular remodeling, either in the veins or the arteries, and they progress through a reactive phase in which you have arterial vasoconstriction plus minus remodeling, and then to the fixed phase or the combined CP-CPH, in which you have fixed arterial remodeling, but also fixed venous remodeling. So let's talk about now the management. Now that we understand that this is a 3-compartment disease, and I'm telling you not to forget about the pulmonary veins when you treat it, let's see how we treat this disease now in our contemporary management schemata. Well, if you look at the guidelines, there's not much there. They want us to optimize the treatment of the underlying condition, treat the substrate, that these patients should be referred to an expert pulmonary hypertension center, and that the use of PAH-specific therapies is not recommended for group 2 pulmonary hypertension. Well, that's not a lot to go on. That doesn't give us a lot to do to help these people. So I want to try to give to you a treatment schemata that I think we should look at that potentially might work in this disease. And again, it's based on the 3-compartment disease. It's one central caveat and 2 co-principles. And obviously the first of these is to aggressively manage left atrial pressure, manage the underlying substrate, and then when you have those into control, start inducing vascular remodeling. And the long-term treatment phase of this has to really simultaneously treat each one of these 3 principles. You cannot treat the underlying vascular remodeling without managing the left atrial pressure or the underlying substrate first, because if you do that and you function just on inducing vascular remodeling, what are you going to do? You're going to reduce pulmonary vascular resistance. You're going to increase preload to remodel pulmonary veins and a non-conditioned substrate. And you're actually going to increase left heart failure and further increase left atrial pressure. Well, that's going to result in pulmonary edema. The pulmonary edema is going to worsen your pulmonary hypertension. You're going to get RV ischemia, a lower cardiac output, and patient compromise. So you must keep in mind those 3 principles, and you just can't add a drug like sildenafil or bosentan or macitentan to people with left heart disease without looking at these 3 principles, and very importantly, controlling left atrial pressure and the substrate first and foremost. So let's talk about some of these caveats. I said the central mechanism really depends on the underlying substrate. And when you think about this, you got to think of, is this an anatomical issue like a mitral stenosis, or a functional issue like HFrEF, or a mixed issue like a valve disease and HFpEF? Is the substrate actually recoverable? Can you reverse HFrEF? Yes. Or can you partially reverse HFpEF? Yes. Or is it fixed like restrictive cardiomyopathy, where you can't really do anything to the underlying substrate? You have to make sure that you control the aggravating factors that make the substrate worse, like obstructive sleep apnea, obesity, diabetes. And then, very importantly, you really have to identify what you're working with. You want to know the specific group 2 variant that you're dealing in, whether it's IPCPH, the reactive form, or CPCPH. Because IPCPH, really all you need to do is aggressive control of the left atrial pressure and modify the substrate, and that disease will shrink away. But when you have CPCPH, you really have to use the combined approach that I suggested earlier. So let's go into the central management caveat. So I call this the 3-prong approach. And the most important thing in treating this disease is to first control left atrial pressure chronically, as well as modifying your underlying substrate as much as you can. And only then should you start considering therapy to actually induce pulmonary vascular remodeling. But when you do this, you really have to think, did I do a good job remodeling those veins? Because remember, the only thing that's going to remodel them is keeping that left atrial pressure low chronically and managing the underlying substrate. And if and when you think you've done adequate job of remodeling the pulmonary veins through tincture of time, that's when you should start about pulmonary arterial modeling. And when you do this, you should really check medications that equally affect the pulmonary vasculature and may also have an added role in affecting LV remodeling. And this is where drugs in the cyclic GMP, PKG axis are very important, because these are drugs that really, really help you in ventricular vascular coupling. And that's shown here. And these are drugs like the PD5 inhibitors or the guanylate cyclase agonist, because these drugs increase cyclic AMP and they increase nitric oxide downstream. These improve coronary function, systemic endothelial function. And in murine models, we know that these drugs can induce some remodeling on the LV. They can reduce hypertrophy, they can decrease fibrosis, and they can actually increase lusitropy independent of blood pressure. So remember that when you're trying to choosing an agent in which you want to remodel these vessels, when you control those other factors first. So is there any proof to what I just said? Does this 3-prong approach work? Well, I think there is some proof. If you look at the treatment of group 2 pulmonary hypertension, particularly CPCPH, in patients that we put mechanical circulatory support devices in, which totally and chronically unload the left atrium if we're working their devices right, you can see that these devices significantly lower pulmonary vascular resistance, just by chronically keeping the left atrial pressure low. And then when you add a drug for vascular remodeling on board, like sildenafil, you can enhance this remodeling even faster. But again, this requires chronic unloading first before you add that pulmonary vascular remodeling in, to make sure you treat those veins through chronic unloading of the left atrium. And you can see similar findings with ERAs and inhaled nitric oxide in these studies. So let's now examine the pieces of the 3-prong approach. And let's talk a little bit about the management of left atrial pressure first, because this is really the key concept. We know that 90% of heart failure hospitalizations result from increased hydrostatic pressure coming from the left atrium, and that the rate of pulmonary hypertension and the heightened pulmonary hypertension is directly related to the rapidity, duration, and magnitude of the left atrial pressure change. And in pulmonary hypertension related to group 2 disease, it's this combination of repeated elevations in left atrial pressure and subsequent acute and chronic elevations in pulmonary pressure that results in acute heart failure and hospitalizations. So how do you manage a left atrial pressure? Well, there's really not a lot we can do. We have a couple of drugs that we know are doing this, which are diuretics. And I encourage you, when you use diuretics in this condition, that it really should be protocol driven, with frequent readjustments based on symptoms or other markers like biomarkers or repeat hemodynamic assessment to make sure that that left atrial pressure is exactly where you want it. We also have nitrates that can unload the left atrium. But very importantly, we now have mechanical unloading, and this includes VADs and some of the new left atrial pumps that are coming out. And these are great devices because they chronically and consistently allow us to unload the left atrium, and we can optimize this with speed adjustments. And when you look at an experiment using chronic unloading of the left atrium using these devices, you could see that in patients with group 2 pulmonary hypertension, that you could get a significant reduction in pressure with chronic unloading of the left atrium. Well, there are other ways that we could do that now. I know everyone's keeping up on the literature, and we now know that we have these intra-atrial shunt devices, whether it's the V-Wave or IASD, in which you make a therapeutic ASD that unloads the left atrial pressure. And these devices have been shown to be effective both in heart failure reduced ejection fraction and heart failure with preserved ejection fraction. And if you look at what these devices do, you can see that in patients who have either using the V-Wave device or the ISAD device, you can see that these devices increase quality of life, and they also improve NYHA class. So they may be an effective treatment for chronic decompression of the left atrium. So now let's switch to the underlying substrate. And I think I'm glad we have a heart failure specialist up at the podium with us, because this is central to what we do, and this is what we know that the community may not do as well as us. So managing the underlying substrate is really buffing heart failure. You have to make sure that these people are on all the right drugs that we know will effectively remodel this substrate. And we have to not only put them on the right drugs, but we also have to make sure that the doses are optimized while we're managing left atrial pressure. We have to control exacerbating conditions, fix anatomical lesions if it's feasible, and according to the guidelines, particularly valvular heart disease, and then perhaps induce more mechanical unloading using LVADs. And this is just an example of how fixing the underlying substrate, in this case mitral stenosis, has a very positive impact on the reversal of pulmonary hypertension in this disease state. Well, let's get to the meat, what everyone's really excited about, which is really how do we manage the actual vascular remodeling that occurs with this disease. So we talked about how to manage left atrial pressure, how to manage the substrate, but how do we induce actual remodeling in these blood vessels? Well, there have been lots of studies looking at pH-specific therapies in treating heart failure. And unfortunately, when you look at the results of these studies, most of them have been negative. These drugs have not been proven to be effective in this disease. And why is that? Well, I think these trials failed because they did not control for pulmonary hypertension, and they also did not have protocol-driven algorithms for controlling the left atrial pressure. So essentially, they were starting these medications, which were pulmonary artery vasoremodelers, in people with active heart failure, people with high left atrial pressures. Well, there have also been studies evaluating pH-specific therapies in patients with heart failure and pulmonary hypertension. So in this case, people were known to have pulmonary hypertension. And when you look at the results of these studies, they're a little mixed. But either you see no difference, or you do see some differences, particularly in drugs using the cyclic GMP pathway, as I showed you before. Some of these drugs do reduce pulmonary vascular resistance or reduce mean pulmonary artery pressure, and can reduce mean pressure without changing the wedge. But the problem with this trials is that there are very few patients in here. These were either single or dual center experiences. And quite frankly, I'm sure you're similar to me. You don't hang your hat on these type of clinical trials. You really want larger trials that really prove the point to you before you affect therapy in someone with a disease state. Well, there now are completed randomized clinical trials that targeted some of these pathways in people with pulmonary hypertension related to left heart disease. And I'm showing you now some of the studies that looked at the cyclic GMP pathway. Now, unfortunately, many of these trials were also unsuccessful. And that may just seem like a paradox to you, because I just told you that these drugs may be helpful in treating this underlying vasculopathy. So why did these trials fail? Well, if you look at them, they failed because they did not control for volume, and they did not have protocol-driven algorithms for controlling left atrial pressure. So they were using these drugs in patients who had active, congested heart failure, in which the left atrial pressure was not controlled and the underlying substrate was not vigorously modified. Now, there are also randomized clinical trials with pH-specific medications in PH with group 2 disease. And again, these are patients specifically with CP-CPH who were stratified either as HFpEF or HFrEF. And unfortunately, these results were also negative. There was no changes in pulmonary vascular resistance or other markers that we want to see. But again, when you look at these trials, they did not use the 3-prong approach before they put in these vascular remodeling. And they certainly did not account for the remodeling in the pulmonary veins, because these drugs, again, were started with no attempt to control left atrial pressure or to do this chronically before they induced remodeling with these drugs. Now, there are a lot more studies on the way with group 2 pulmonary hypertension and some pH-specific medications, and some of these results have not yet been published. We'll be seeing some of these at the upcoming ACC and ATS meetings this year. So we'll see how these trials fared in this arena. So again, when we think about managing group 2 pulmonary hypertension, I hope I have convinced you that you need to have the 3-prong approach. You can't forget about the pulmonary veins. You have to lower left atrial pressure chronically. You have to modify the underlying substrate. And you have to do that for a few months chronically to make sure the pulmonary veins are remodeled before you induce remodeling of the arterioles. And when you do this, you have to do it in a continuous fashion with consistent monitoring that consists of multiple touch points with the patient, a multimodality approach, which we'll review, and then you have to treat and monitor simultaneously. So now let's jump into how do we actually monitor this disease in the last 15 minutes or so of this talk, because I think this is where a lot of the fun stuff is that's developing in cardiology. So let's start with how do we monitor left atrial pressure? Well, conventionally, we do this just by visits to the clinic. We do physical exams, we do vitals, we look at labs, we measure weights, we do neurohormone testing. We even have home telemonitoring now where we can check vital signs and weights at home. And then we have implantable hemodynamic monitoring, including impedance testing, left atrial monitors, and PA monitors. Well, what do we know about these? Well, we know when we do visits to the clinic and weights that these suffer from really poor sensitivity and discrimination for identifying people who are wet or not wet. This is a really late manifestation of the disease. We also know from the guided trial that neurohormones may not also be a good way to manage these patients with chronic active heart failure. When we look at telemonitoring using home weights and vital signs, these have also been very disappointing clinical trials in reducing hospitalizations related to heart failure. So that brings us to implantable hemodynamic monitorings and how they actually may be useful in this disease state. In order to understand that, I want to show you what I think is a really good paradigm for where these type of markers and monitoring systems fall into place in the continuum of decompensation in heart failure, trying to really understand the mechanisms. And this is, this insight came from continuous physiological monitorings. And you can see that the things that we use in clinics, symptoms and weight change and vital signs, they are a very, very late manifestation of this disease right before someone's going to dump into the hospital. So they're not very useful in giving us long-term lead time in identifying this disease. Now we look at the hemodynamic monitoring, you can see that filling pressures and changes in filling pressures are a very early sign of decompensation. And that monitoring this can give us significant lead time to treat a patient before they wind up in the hospital. And that's the whole premise of using these indwelling hemodynamic monitors. Now, one of the things that I find very useful in managing patients in heart failure in my own clinic is impedance monitoring. And we can do that using either the Optival or the CoreView from the St. Jude's device. And there actually was a left atrial pressure monitor that we were trialing in the clinic at one point, made by St. Jude, called the Heart Pod. And maybe you guys at Methodist may have participated in this particular study. But impedance monitoring is very interesting. It really tells you the amount of fluid that's in the lung by measuring the impedance between the indwelling ICD leads and the CAN. And when you look at these devices, this is an example of the Optival, you can see that changes in thoracic impedance. When it decreases, that means that someone's getting wet. And you can identify this very nicely and very sensitively with these devices. And using the Optival, which is the inverse of the impedance, you can set thresholds for volume accumulation where treatment can occur. And the higher these spikes and the longer these spikes, the worse the decompensation is. So I have used this very readily in my clinic and trained my nurses how to utilize these devices so that I can chronically keep left atrial pressure in check. And when you look at these devices, you can see that they're a whole lot more sensitive in picking up abnormal fluid content than just managing the weight. So I use these very readily in clinic, and I would encourage you to use these also if your patients are equipped with these devices. Well, what about monitoring the underlying substrate? Well, again, we have the same things we see with visits to the clinic. We have neurohormone testing. We have imaging now that we can do exercise testing and also repeat invasive hemodynamics. But again, these suffer from the same sensitivity and also require physical touch points with the patient in order to predict what their volume is. So they may not be as readily available or useful to manage this disease in the long term. And so let's look at the monitoring of vascular remodeling now in right ventricular status. Well, again, we can utilize the same things that we do with the underlying substrate. But again, as I mentioned, the problem with this is we're limited by the number of physical touch points with patients to do this. Someone has to come in to get an echo. Someone has to come in to have an exercise test. Someone has to come in to have a right heart catheterization. And so they're not very practical in managing these patients on a day-to-day basis. And that's where the concept of these indwelling hemodynamic monitors come in. As I showed you, changes in filling pressures give us a lot of lead time to prevent decompensation in these people. But currently the way we do this is with the right heart cath. And we know there are a lot of shortcomings to doing right heart catheterization. First of all, it's invasive, it's costly, and it's only a single time point assessment that's done in the supine breast condition. There are a lot of problems with this. And that's where these indwelling hemodynamic monitors really came into play. The first one that we had on the market was the Chronicle ICD. And I did a lot of the clinical trials with this. And this was a great device. But unfortunately, they had problems with the leads that were the hemodynamic sensors. And this device never came to market. But now we also have the CardioMEMS device and also the new Endotronics device that we can use that is indwelling pulmonary artery monitor that we can use for long-term evaluation of these patients. And this is a look at the CardioMEMS device, and I implant these regularly. It's an over-the-wire implant. The sensor is placed via right heart catheterization into the pulmonary artery and allows you very accurate and sensitive depictions of the pulmonary artery pressures. And this is just a picture of a chest X-ray with the CardioMEMS device in. So what does this device give you? Typically, it will give you just three pressures. The PA systolic, which is shown in red, the mean pressure, which is shown in blue, and the diastolic PA pressure, which is shown in green. And you can monitor these on a daily basis. And you also have a nice algorithm which gives you the area under the curve of these pressures shown in the latter portion of the gray section. And when this device was utilized in heart failure, and the Champion trial is the big trial, you could see that those patients with heart failure who were managed with this device had a significant reduction in heart failure hospitalizations compared to those who were not managed with the device. And this led to the device's approval for the use of heart failure in the US. Now, there have been a lot of modifications in this device, not in the actual integrity of the device, but how we actually can use the device in clinical practice. And this is one of the things that some of the research I did as part of an NIH trial that we had is developing a mathematical model based on the PA pressure waveform and PA velocity profile that can now allow us to determine the stroke volume using the CardioMEMS device. And since the device also detects heart rate, you can get an estimated cardiac output that is fairly sensitive and fairly robust and fairly repeatable. So is there any signal that this technology would be useful and safe to utilize in patients with group 2 pulmonary hypertension related to left heart disease? And I think the answer is yes. When we went back and dug through the champion data, we identified there were a number of people who actually had pulmonary hypertension in this group of treated patients. And some of these patients truly did have combined precapillary, postcapillary pH with elevated PVRs, a TPG, and transpulmonary gradients. And when you look at these patients who had pulmonary hypertension, you can see they had similar reductions in heart failure hospitalizations, and also a reduction, a combination of heart failure hospitalizations and death. So this device indeed might be useful in helping to treat patients with group 2 pulmonary hypertension. Now, when you looked at the hospitalization rates in this cohort, you can see that they were markedly reduced in the actual treatment arm, and they were significantly reduced even in those patients who had CpcPH with elevated transpulmonary gradients and elevated PVRs. So again, a device that might be very useful in managing these patients. And this is just an example of me treating someone with group 2 pulmonary hypertension, utilizing this device and the 3-prong approach that I told you about earlier. So let me orientate you to the slide. On the bottom of the slide, you see a blue, green, and red. Those are the traditional CardioMIMS pressure waveforms. The blue systolic, the mean green, and the diastolic red. And on the top, you actually see the cardiac output algorithm being utilized, with the orange being the cardiac output and the purple being the total pulmonary resistance. Now, this is a patient who I treated who had HFpEF, who had group 2 CpcPH, so an elevated PVR in the setting of heart failure preserved ejection fraction. And you can see that this person had very severe pulmonary hypertension with PA systolic pressures in the 80s, with reduced cardiac output and a very elevated total pulmonary resistance. So what do we do for this person? We managed the substrate, and we controlled left atrial pressure first. And we did this for a period of time. And as you can see, we had nice reductions in pulmonary pressures, an increase in cardiac output, and a reduction in total pulmonary resistance. And then we kind of plateaued at a point. And that's when we started adding a pulmonary vascular remodeling agent. So we controlled the substrate, we managed the left atrial pressure. I wanted to make sure that those veins were remodeled. And then I added my remodeling drug using something in the cyclic GMP pathway. And you can see with that addition, we had a much significant reduction in pressure, a nice reduction in total pulmonary resistance, and a further increase in cardiac output. Again, alluding that this 3-prong approach may actually help. And we did this at such a point we could actually reduce the diuretics later in this person's treatment. So this is another patient which we used the 3-prong approach with the CardioMIMS device. And this was a patient with very, very severe heart failure, reduced ejection fraction. And this person was actually a dean at the medical school and was unable to work anymore. And this patient obviously was maximized on oral vasodilators, optimized as much as we could with diuretics, including at a point where his heart failure was so bad that we had to initiate IV milrinone. Now, his pulmonary vascular resistance was so high that it precluded him from being evaluated for cardiac transplantation. And so in this hatched line, this is a further medical modification that resulted in really very little change in their pulmonary vascular resistance, even with the addition of an inotrope. And so at this period of time, in around August, we decided to place an LVAD. And you can see with the placement of the LVAD, that there was a very significant early drop in pulmonary pressures. Again, we did that chronically over a month or two, made sure we had chronic unloading, and then we started a pH-specific medication, and you can see how significantly the pulmonary artery pressures dropped after this, and they improved so much that we were able to list this person as a 1B for transplant, and he also returned to work as the dean. Now, when we look at some of the other parameters that we can now get with the CardioMIMS device, in this case, the cardiac output in blue, and looking at it in the context of the systolic pulmonary artery pressure, you can see the changes that occur with these different management systems. When we placed the VAD in, of course, the cardiac output bumped up and the pressure reduced nicely. And then when we added the pH-specific medication, you can see the further improvements in cardiac output and the further reductions in pulmonary artery systolic pressure. And then in this last slide, where I show you some of the other parameters you can get with the CardioMEMS device using the stroke volume algorithm, with RV stroke work in red, the stroke volume index in blue, the total pulmonary resistance in black, and the cardiac efficiency in orange. And again, you can follow the changes in these hemodynamics with the induction of this three-pronged system: chronic unloading of the left atrial pressure, managing the substrate with the LVAD, and then finally a delayed start of pH-specific medications to remodel the arteries after we were sure that those veins had been remodeled. So again, two examples of where this three-prong approach does work. Now, and some of my last thoughts, I just wanted to conclude with telling you that you have to be careful when you do this. Remember, this is not guideline-approved therapy yet. These are mainly my opinions and observations from the data that I think this three-prong approach will work. And if you do ensue this three-prong approach and you do use pulmonary vascular remodeling in this condition, you have to be careful, because there are a lot of drug-to-drug interactions with the drugs that we commonly use in heart failure. And there are also a lot of drug end-organ interactions, particularly with people who have underlying liver disease and renal disease, that you have to be careful about when you use these medications. So if you're going to use the three-prong approach, please make sure you use a sensible amount of caution when you use these medications in this disease. So remember, the guidelines say refer to a pH center and don't use pH-specific medications. But if you are, I want you to remember the three-prong approach, and do not forget the pulmonary veins when you're treating these patients. And with that, I thank you for your time and your listening. And we have about 15 minutes for questions that I'd be happy to entertain.
Thank you, Dr. Benza. That was an excellent talk, and I'm sure me and Dr. Hussain, we learned a lot in this. We do have a few questions from our audiences, and just to remind everyone, you can send your question by web through pollev.com, enter DeBakey, or by text to 37607 and text DeBakey. Dr. Hussain, do you have any comments?
Yes, so Dr. Benza, it's an excellent, outstanding overview of Group 2 pulmonary hypertension, and we really appreciate it. And so just a couple of, there are several questions that are coming, but just one comment, or rather based on your three-prong approach, that it's more of a center experience that I want to share and get your thoughts about. So in terms of patients with heart failure with preserved ejection fraction who Group 2 pulmonary hypertension, in particular, who have a PVR of greater than 5 Wood units, we have sort of a single center experience between me and Dr. Guha. We have about a series of 40 to 50 patients that we treated with the combination of Entresto and sildenafil. And we did their pre and post right heart caths, and a fair number of those patients had improvement in NYHA class, and actually either normalization of PVR at 3 to 6 months, or definitely less than 3 at the repeat right heart catheterization. So kind of going towards the point of what you're talking about in terms of the three-prong approach, in terms of managing the underlying substrates that's responsible. So I don't know if you have said something similar that you may have adopted in patients with heart failure preserved EF, especially with the new onset or new coming of the SGLT2 inhibitors, which we have started doing, but we have not tested that in specifically patients with combined pre and post-capillary pulmonary hypertension.
Yeah, thank you. I use a very similar approach to you. I make sure that I am modifying the substrate using contemporary guidelines. So I do use Entresto, I use spironolactone, and I use SGLT2 inhibitors in that disease. And in this disease, the use of drugs of the cyclic GMP pathway, I think, is a good idea, because as I showed you, they do improve lusitropy in these patients. So I think it's very sensible to use those. I put a lot of patients who have CVCPH related to HFpEF. I use a CardioMEMS device in these patients so that I can manage both their pulmonary pressures and get a sense of what their underlying filling pressures are. Now, it's a little tricky to do that with the CardioMEMS when you have CVC pH, because you know the PA diastolic no longer accurately represents the wedge pressure. So I try to get a good idea of what the diastolic pressure gradient is when I do their caths initially, and I use that to kind of guide my diuretics to know when I think I've actually decompressed the patient. The other thing I do importantly in those patients is I check for reactivity when I do their caths, because in people who are still very reactive in terms of responses to nitroprusside or nitric oxide or to nitroglycerin, these people have not yet undergone permanent vascular remodeling. And those are people whom you may have earlier treatment success on if you use that combined approach, because you don't have to worry as much about venous remodeling in those reactive patients. You know that it's not remodeled, and you won't run into that obstacle of causing pulmonary edema in those patients. But in those who are not vasoreactive and who I'm really sure have likely combined venous and arterial remodeling, I use the CardioMEMS approach in my practice to make sure I accurately decompress them. Now, the other thing I've been doing right now, which I think is kind of a nifty trick, is I have a REDS device that I have available in my heart failure clinic, so that when I am seeing these patients, I make sure that I have 3 neutral REDS readings to make sure that I've really decompressed the left atrium before I will use pH-specific therapeutic. Again, that is my opinion. It's not a guideline documentation, but I do find that using fluid volume assessments with the REDS device in patients with HFpEF, particularly since most of the time they're very difficult to examine, could really help you in determining when that point is that you feel safe in putting that vascular remodeling on.
Thank you, Dr. Benza. We've got quite a few questions, and I'm not sure if you'll be able to cover all those, but some of them are very interesting questions. So, does sinus rhythm restoration in patients with atrial fibrillation have any significant effect on left atrial pressure? Does it increase or decrease left atrial pressure? That's one of the questions.
Well, I think in patients who have HFpEF, it is critical to try to restore a normal sinus rhythm, because I think that helps with the underlying substrate, it helps with symptoms, and in the long term, you actually will reduce left atrial pressure because the heart is operating on a better curve. And so I do in my practice recommend restoration of sinus rhythm, particularly in patients with heart failure preserved ejection fraction. In heart failure reduced ejection fraction, I'm not as convinced it's as helpful. Obviously, if we try to modify the substrate and we're unable to do that, and people have poorly controlled atrial fibrillation, we'll make some attempt at modifying that, particularly if it's paroxysmal atrial fibrillation, where we know that ablation can be very successful. I'm a big proponent of that, but obviously in people with huge left atriums who have really bad left atrial non-compliance, sometimes it doesn't really help. That left atrial non-compliance is another big problem, and that's why I mentioned really using chronicity of time. It's not just a matter of dropping left atrial pressure. You have to keep in mind that left atrial compliance is markedly abnormal in these patients, particularly in HFpEF, when they have long-standing disease.
We have a few more. Could targeting arterial resistance be used in isolated type 2 PH? Basically,
I'm sorry, say that again, Cindy.
Arterial resistance. Targeting arterial, I think that probably they meant by the systemic arterial resistance, or SVR, be used in isolated type 2 PH. This is a...
Well, I think that's a good question, and managing the SVR obviously is part of the gold standard for managing patients with heart failure reduced ejection fraction, and in people who have hypertensive cardiomyopathies with HFpEF, managing the SVR is very, very important. So getting that under control is very good. Now the problem is when you have someone who has combined precapillary, postcapillary pulmonary hypertension, you have to be very, very careful about lowering the SVR when you're in a position where the SVR and PVR are very close. Because if you drop the SVR below the PVR, you're going to run into big problems. That's the time when the RV will get ischemic, you'll get bradycardia, and bad things will happen. So yes, I do treat the SVR, I do turn the guidelines, I try to optimize their left heart failure using those drugs, but I am very, very cautious in not making that resistance drop below the pulmonary vascular resistance. You got to be really careful about that.
Okay, I don't think we will be able to cover all the questions. We're getting pretty good enthusiasm here.
I'm a great emailer too, so please feel free to share my email.
So another question is, do you think pH might just be a marker of more severe heart failure, and that's why medication to treat it failed to reduce MACE, like the case of hyponatremia?
I love that question, and because I've asked that question to myself multiple times when I've been thinking about designing this algorithm. And this three-prong approach is part of a trial that's being evaluated by the NIH right now through a grant. And we really thought about this. I do believe it is both a marker, but also part of the intrinsic pathophysiology that worsens mortality. I think it's both. And the reason I think it's both is that when we have patients who have optimized left heart failure, they're on all the right drugs, they're all on the right doses, and they still have a much higher mortality if they're optimized and they have persistent pH. So these are the people who have CBC pH, not the ones that have isolated postcapillary pH, which usually melts away when you do a good job monitoring, managing the underlying substrate. So I think that the true answer to this is that it's both.
I guess I could probably have one more question here. Could you explain how you are driving TPR from CardioMEMS?
Yes. So remember, the total pulmonary resistance is not the same thing as pulmonary vascular resistance. Pulmonary vascular resistance, you need the wedge pressure. So to calculate total pulmonary resistance, you just really need the cardiac output and the mean pulmonary artery pressure. To do that. So that's a simple mathematical derivation that you get from the pressures and the stroke volume that you get with CardioMEMS. I should say that stroke volume algorithm is not available for you guys to use yet. I'm able to use it because we helped design that protocol, but I can tell you it is with the FDA. And the FDA is closely looking at this algorithm to see if it's something that they like and trust. And if they do, we should have this stroke volume algorithm ready to use hopefully by 2023.
Dr. Benza, a quick question. In terms of your practice in your cardiac catheterization lab for patients who do, when you're trying to distinguish reactive from combined pre and post capillary, are you routinely doing nitrite challenges, or you rely more on diastolic pressure gradient, and what has been your approach, and how are you doing this?
In my own approach, I use inhaled nitric oxide. Okay. I like that drug. Particularly people who are tenuous, where I worry a little bit about that systemic vascular resistance using nitride or nitroglycerin. I like nitric oxide as my preferred agent to do that reactivity testing. Right. And I use 20 parts per million. I don't really go above 20 parts per million because if you look at the efficacy curves, you're really on a flat part of the curve when you pass 20 parts per million. So I know some people go up to 40 parts. I don't typically do that. I will start right at 20 parts per million.
Thank you.
Okay, I guess we could just do one last question.
Okay.
This is a little interesting though. Is there a threshold for pulmonary pressure beyond which an anticoagulation could be useful to prevent events and disease progression like vascular microthrombi in patients with no or other indication for anticoagulation? I guess the question is more focusing if there is any role of systemic anticoagulation in sort of group 2 or combined pH.
Yeah, that's a great question. Yeah. In the guidelines, anticoagulation is currently not given a recommendation outside a very small portion of patients with group 1 disease. In my own practice, however, in patients obviously who have very bad right heart failure with a lot of venous congestion, particularly in those who have had events in the past, I often would recommend doing some sort of anticoagulation. A lot of times that's made easy for you because a lot of these patients get atrial fibrillation, and you have an excuse to use a NOAC. But I really consider those, particularly in those who've had prior events and those who are having a really hard time decompressing the right ventricle.
Okay.
But it is not a guideline recommended usage.
Okay. Thank you, Dr. Benza. Thank you for your time with us today, and thank you everyone for joining us. And if anyone has any more questions, feel free to reach out to me and I'll connect you with Dr. Benza. So I guess with that we would conclude here. Have a wonderful day.
Okay, thank you so much.
Thank you so very much. It really was an honor to present to everyone today, and I look forward to the days where we can actually meet again and do these things in person.
Thank you so much.
Thank you.
Bye now.